Thank you for inviting me here. I said I don't need a microphone, but if I can't be heard at the back, you probably should get hearing aids. I'm going to talk today about managing thrombosis. I wanted just some comments on the case to start with. I wrote notes to myself. So the first thing is, you're entirely right. Where are you? Entirely right about the D-dimer. I kind of felt like I was at home because this patient had way more tests done than she needed. What she really needed out of that whole list of tests was probably, the CTPA is probably useful, but you could have done an ultrasound of her leg, and if she'd had a blood clot in her leg, you could have stopped there. She didn't really need anything else. She did not need the echo. To answer your question about thrombolytics, there's a study called PEITHO, P-E-I-T-H-O, where they took patients that she would have been eligible to go into and very clearly showed that patients who got thrombolytics had much higher rates of bleeding, including intracerebral bleeding. And even Sam Goldhaber, who's the world guru of thrombolysis now, would say that that woman does not, she should not be considered the thrombolysis. What you said for indications for thrombolysis were entirely correct. The D-dimer was definitely not indicated, and the reason why it was not indicated was exactly the reason you said. If the person has a high pre-test probability of pulmonary embolism, there's no additional value to doing a D-dimer, because if the D-dimer is negative, you should test for PE, and if the D-dimer is positive, you should test for PE, so it has no additional discriminatory power. The thrombophilia, who asked the thrombophilia question? Someone. So thrombophilia testing is an interesting problem. She does not need thrombophilia testing done. She might need screening for a malignancy if she had any signs, symptoms, history to suggest a malignancy. If you found, say you did thrombophilia screening and you found she had a low protein C level, here that's very likely to be a false positive because the lab quality here, I know we're having run the labs in Canada for many years, are not very good. But more importantly, the NICE, which is the US or the UK guideline group, which many of you will have heard of, the NICE panel, they've actually looked at this issue and they said who should get thrombophilia testing done. And the only people they said should get thrombophilia testing done are people who are discontinuing anticoagulants. And this person has an indication for lifelong anticoagulants, so she doesn't need to have the testing done because it's not going to influence your decisions about treatment strategies. You might say, well, wait, she's only had one child, she may want more children in future. That's fine. You're going to anticoagulate her during pregnancy anyway, so there's no additional discriminative value to checking her for malignancy or for thrombophilias, other than things which are specific to Uganda, which might be, for example, a malignancy that she might be predisposed to. But in our system, she should not get thrombophilia testing. And some of you may have heard this story. I ran the labs in our region for 8.5 years, and we had a vast amount of unnecessary thrombophilia testing done. And so the solution was very simple. And one day I wrote a letter saying, we will not do thrombophilia testing anymore, ever. And so we stopped offering it that day, and we don't offer it now. And we just never have call for it. Nobody really needs to have thrombophilia testing done. Sometimes when they're coming back to the hematology clinic, a year later, and you're trying to make decisions about whether they should continue or not, you might think about it then. But in the acute setting, where the patient's going to be anticoagulated, there's no role for thrombophilia testing at all, for sure. So that's my thoughts on the case. It's a great case, thank you very much. Realistically, if you didn't have the CTPA, the pre-test probability that she has a pulmonary embolism is probably 99%, based on the history, the past history of the previous event, her clinical presentation. If Henry called me with this person and said he can't get any diagnostic tests, would I be comfortable anticoagulating that person? The answer is absolutely yes. She needs to be anticoagulated because the likelihood she's got a pulmonary embolism is very, very high. And I base that mostly on the fact she's had a previous event, which automatically inflates her risk. And her presentation was with an acute event, not with something that would be more chronic or more complicated. So those are my thoughts on the case. I think it's a great case. Thank you for presenting it. And something I think pulmonary embolism kills young people, so if you miss it, people die from it. So it's an important thing not to miss. All right, if I could have my first slide. So today I'm going to talk about thrombosis and managing it in 2018. I'm going to tell you some stuff that's relevant to Uganda, and I'm going to tell you some stuff that probably isn't. And I'll try to frame it in a Ugandan context as much as I can. Henry didn't say, I've been to Uganda many, many times over the years. I don't know how many, I should go back through my passport, but more than 10 times. So I kind of know how the Ugandan healthcare system works. Those are my conflicts of interest. The ones that are relevant for this presentation is I've done work with the companies that make some of the new anticoagulants that I'm going to talk about today. So if I have the next one. So the big change in thrombosis management in the last 10 years has been the introduction of a whole series of new blood thinning drugs. I'm going to talk a bit about them. I know that rivaroxaban or Xarelto in Uganda is an expensive medication, but I'd like to make the case that if a patient can afford it, it's probably your preferred agent for most forms of thrombosis, because although warfarin is cheap, warfarin is very, very difficult to manage in Canada, where we have great access to lab tests, and in Uganda it's going to be extremely difficult to anticoagulate with warfarin unless you have access to excellent lab services, and Henry and I have discussed this many times, and very few people in Uganda have excellent access to laboratory testing. The first question we asked ourselves is, you hear the term NOAC and you hear the term DOAC for these drugs. We want you to call them DOACs. The N in NOAC stands for novel. And these drugs have been around for 10 years, in some cases 15 years, so they aren't novel anymore. And there's a medical legal concern or a medical care concern with calling them NOACs, because there have been cases in hospitals where the word NOAC, N-O-A-C, has been confused for no anticoagulant. And that's resulted in patients having bad outcomes and lawsuits. So in fact, we want you to stop using the term NOAC. We want you to use the term DOAC, and you should also try to specify whether it's a 10A inhibitor or a 2A inhibitor, because that also causes some confusion. Now, warfarin has been around for a long time. It was first used in the 1950s, and there are other drugs too, acinocumarol and fenprocuman, around the world. Warfarin is dirt cheap. It's easy to access. Everybody knows what warfarin is. If you go into the hospital in Gulu and say you're on warfarin, people know what that is. If you go into a hospital in Kazakhstan and say you're on warfarin, people know what that is. So it's got brand recognition. It's inexpensive. It's highly effective. So it should be a great medication, but it's not. And it's not a great medication for the list on this side. It requires monitoring, and a very common problem that occurs in Uganda, and I've seen this many times myself, is the patient will be sent home on a typical dose of warfarin, like 5 milligrams, and they don't return for follow-up, and they just are taking that 5 milligrams, which may be far too much or far too little for them, and that's dangerous because they're either being undertreated or overtreated. There's a lack of availability of testing all over the world, but particularly here. Most importantly, there's variability between and within individuals. So the smallest dose of warfarin that I've ever seen a patient take per week is what? Guess what the smallest dose of warfarin a patient in our clinic required to maintain anticoagulation, milligrams per week? 1.5. So the smallest dose per week is 1.5 milligrams per week. And what's the largest dose per week of a patient that I have ever been involved in the care of? Just guess. 50. Keep going. 100. Keep going. 200. Keep going. 300. Keep going. The highest dose of a patient that I have ever been involved in, she required 150 milligrams a day to maintain an INR between 2 and 3, so she took 850 milligrams a week. So warfarin is a unique medication in many ways, but one way is that the dose, she ate it with a bowl in the morning. So warfarin is a unique medication because there is no predictability to the dose. You can say on average, like most people in this room are pretty young, so on average you're going to take around 7 milligrams per day, and if we put you all on warfarin and checked you after a year, the average dose would be somewhere around 7 milligrams per day based on statistics. But the individual dose in this room would likely be probably somewhere between 10 milligrams a week and 70 to 80 milligrams per week, maybe higher than that. Your diet has a lot more vitamin K in it than our diet, so on average you're going to need more. So the problem is that you just can't figure out warfarin without excellent quality lab testing. In North America, where obviously I work, about 6 out of 10 times patients are in the range. So we have about a 60% time in therapeutic range. I don't know what it is in Uganda, but I can guarantee you it's not that good. And anytime you're below the range, you're at risk of thrombosis, and above it, you're at risk of bleeding. And the bleeding is bad kinds of bleeding, right? Intracerebral hemorrhage kills people on warfarin. There's no question about that. So warfarin has been a great medication when we didn't have any others. It's a great medication when you can't afford any others because it's highly effective. But warfarin is a terrible drug if you can access other drugs. And if you came into our clinic today and you had this lady, we would not discuss warfarin with you. We do not use warfarin to treat deep vein thrombosis or pulmonary embolism anymore, except if the patient truly can't afford one of the new agents, which is very uncommon. Next slide, please. So I'm not going to go through this in any depth. I'm just going to say that this is getting really complicated. There are many, many anticoagulants, and in fact, if you go on to the next slide, this is a list of medications which are currently available that can anticoagulate you on the left. So that's a list of some of the anticoagulants, the antiplatelets, and it's really, really confusing, right? There are many, many of these drugs. And so what we need to do in 2018 is you need to understand one or two drugs that work for the indication that you are going to treat a patient for, and then learn a lot about those drugs, rather than trying, no, I need to know these drugs, all this list, but you don't need to know this whole list. Next slide, please. So APIXABAN is one of the commonly used new agents. It goes under the trade name of ELIQUIS. It's an oral direct factor 10A inhibitor. It's highly effective, it's rapidly acting, so when you take a dose, it has a peak effect in about 2 to 3 hours. It lasts for 9 to 14 hours, and it's predominantly excreted by the liver, so there's no risk of bioaccumulation. The reason I put this up here is that it's not used at all, I don't think, in Uganda, but it has some advantages over rivaroxaban, and I'll talk about that in a bit. So this drug may come at some point to Uganda in the future. Could I have the next slide, please? It's been studied for venous thromboembolism prevention after orthopedic surgery. The big market in North America is atrial fibrillation, medical prophylaxis, long-term treatment of acute coronary syndromes, acute venous thromboembolism, and medical prophylaxis. Next slide, please. And it's become the default anticoagulant in many cardiology practices for patients with atrial fibrillation. The advantage of APIXABAN over rivaroxaban is that the studies suggest there's a lower risk of bleeding. Whether that's study design or reality, I don't think we know, but the evidence that's available suggests that APIXABAN may have a lower risk of bleeding. And there's very limited doses of APIXABAN. You either really take 5 milligrams or 2.5 milligrams. There are a couple of indications for other doses, but generally speaking, people tend to be on one of those two doses. The disadvantages are that APIXABAN is twice a day, and I take a once daily antihypertensive, and I frequently forget. One of the people I'm traveling with today, as she was sitting down in the meeting earlier, said, "Oh, I forgot to take my Malarone this morning." That's a once daily medication. It should be not hard. You should remember, a twice daily medication is impossible to remember in my books. I just don't know how you'd ever do that. And the problem with APIXABAN is that there's a propensity for people to use the wrong dose. So in the studies that were done of atrial fibrillation, the dose was 5 milligrams twice a day, and about 10% of people were dose reduced to 2.5 milligrams twice a day, based on criteria that we won't get into. In Canada right now, about 80% of people who get a prescription get the lower dose. And in the US, the numbers are the same. So in fact, it's being inappropriately prescribed at a low dose. So the danger with APIXABAN is that the 2.5 milligram dose, people want to use it because they think it's safer, but they're losing efficacy when they pick the wrong dose. So when you're using these drugs, it's very, very important that you use the correct dose. You don't muck around with the doses unless you have evidence for it. Next slide, please. Rivaroxaban or Xarelto, similar drug. It's a 10A inhibitor. It has high bioavailability, rapid onset of action, a half-life that is initially about 9 hours, increases to 12 hours. You get 24 hours of anticoagulation after a single dose. And one of the really important things about rivaroxaban and APIXABAN is that there's few or no important drug interactions, except there is one for you guys which is not relevant for us, and that is a lot of the highly active antiretroviral agents cannot be used with these drugs, because if you're on certain heart drugs, you will metabolize the rivaroxaban and APIXABAN very quickly, and you essentially have no anticoagulant effect. So if the person's on heart, and you need to check the medication list they're on, and you need to check to see whether or not it's a contraindication to rivaroxaban or APIXABAN. Next slide, please. It's been investigated for the similar sort of set of things as has APIXABAN, and I'll highlight a few of those. Next slide, please. Rivaroxaban has become the default anticoagulant in lots of different clinical situations. It's used widely for venous thromboembolism, and I think it's used widely in atrial fibrillation. And I get the feeling that in Uganda, from talking to people, rivaroxaban is your only choice other than warfarin, at least your only choice that you can easily access. And so it really has become a default anticoagulant. It has one big advantage, which it is once daily dosing. And it has a huge disadvantage in that there's a whole bunch of different doses. So as I'll show you, there are 2.5 milligram tablet, 5 milligram tablet, a 10 milligram tablet, a 15 milligram tablet, and a 20 milligram tablet. And the doses are all different for different indications. For some indications, you give it twice a day. For some indications, you give it once a day. So it's kind of a recipe for a drug confusion mess. And that's why if you're going to use rivaroxaban, you need to learn the doses that are appropriate for the people that you're seeing. Next slide, please. So rivaroxaban is moving forward very quickly. This is from last summer. This is a study called COMPASS. And I put this up because we think about these drugs for venous thromboembolism. We think about them for atrial fibrillation. This is a study that John Eichelboom, who's at McMaster, led, was published in the New England Journal last summer, which randomly assigned almost 28,000 patients who had stable coronary artery disease to either get 2.5 milligrams twice a day of rivaroxaban plus aspirin, rivaroxaban 5 milligrams twice a day, or aspirin once a day. And the primary composite outcome was cardiovascular death, stroke, or myocardial infarction. And the study was stopped early for superiority of the rivaroxaban plus aspirin arm. And this is leading to this drug going forward for approval in lots of different countries, North America and Europe. And it's great because this is something to be great for Africa. If people can afford it, the 2.5 milligram dose, the 5 milligram dose, easy to use, inexpensive, relatively, doesn't require monitoring. And if you have had a heart attack, the combination of aspirin plus rivaroxaban is an appealing combination with a big but. And the big but is you have to remember to use it. It's reasonably expensive. And patients are going to be on this forever once they start. So the real concern I have with this study has nothing to do with the study. If I had a heart attack tomorrow, which is entirely possible given my body habits, I would I'd be on aspirin and I would take rivaroxaban at these doses because it's highly effective. The big problem is that this is now an even funnier dose. So we said for PE, the long-term treatment is 20 milligrams once a day. Here we've got 5 or 2.5 twice a day. Like that's really confusing now. You've got a once daily dose and you've got a twice daily dose. Next slide, please. I'll talk briefly about dabigatran. The reason I'm going to talk about dabigatran, I don't think dabigatran is available in Uganda. Is it available? No. The reason why you might want to just hear about dabigatran is it's going to become generic in lots of countries this year. And so it will become cheaper. And so it may become available in Uganda, and it's a perfectly good drug. And it's the first to go generic, and it'll be the least expensive by far. It has a couple of different twists. So the most important of them is that it is contraindicated in people with renal insufficiency because it's highly renally cleared. It has no food interactions, and the problem is going to be that if you're going to use dabigatran, you need to know what the person's renal function is, because if they have moderate to severe renal insufficiency, they're at high risk of bioaccumulation, which can cause bleeding. Next slide, please. It's been investigated for the same kind of list, and as I said, it's the first to go generic, and so it'll be generic in Canada. There's a possibility it'll actually be generic this year, and so if it becomes generic, it'll be really, really inexpensive. The other advantage it has, if you can go to the next slide, please, is that it actually has a reversal agent. So APIXABAN and rivaroxaban don't have a reversal agent. That's completely irrelevant. You don't have reversal agents for warfarin in Uganda, so that's not a choice for you guys. In the United States, to a greater extent, and in Canada, to a lesser extent, reversal agents may become available for rivaroxaban and APIXABAN, but for dabigatran, the reversal agent already exists. It's called idarucizumab. It's highly effective. The drug itself is less expensive and about to be generic. It has a limited number of doses. Effectively, there's only two, 110 BID and 150 BID. I don't think you need to talk about the lower dose. And the major disadvantage of the drug is it bioaccumulates with renal insufficiency. Other than that, it's a pretty good drug. So if one of the Indian companies that makes generics wants to come along and market this, that might be an appealing drug in Uganda because it's going to be less expensive than the other choices, and it's going to be available sooner. If I could have the next slide, please. So the future is a gradual decrease in the use of vitamin K. However, they won't disappear, and I'll tell you why they won't disappear in a second. They'll continue to be used for mechanical valves in some patients with a very high risk of thrombosis and patients who can't take DOAC. So, if you can't get a patient rivaroxaban, then there's no reason not to use warfarin. But if you can get a person rivaroxaban, then you should use rivaroxaban. And in that case, you had the cost to the patient of all those tests she had would have paid for years of rivaroxaban. Really, honestly? So, if you said to myself, I'm just going to do an ultrasound on her leg, and I'm going to take all the other money that she spent on those tests, and I'm going to use it to buy rivaroxaban, you'd have got her several years of drug, right? So think about those kind of decisions when you're making decisions. The DOACs will gradually replace warfarin, particularly once they're generic. And what will happen is that warfarin is a really hard drug to use now, and in 5 years it's going to be even harder because people are not going to be familiar with it because it's just not being used very much. So I'm going to talk a bit about bleeding with the direct oral anticoagulants because people talk about bleeding with rivaroxaban and APIXABAN. Next slide, please. Chatry, who was a master's student of mine, published this paper a couple of years ago. So what he did is he took all of the studies that led to the approval of the direct oral anticoagulants for all indications. The study enrolled we looked at data from 104,000 patients, and we looked at the rates of different kinds of bleeding and other complications. And you can see here that for major bleeding, when it says relative risk, that means that if you're on a DOAC, your risk of bleeding is about 28%, your risk of dying of having major bleeding, is about 28% lower than if you're on warfarin. So major bleeding is about 28% less common than if you're on warfarin. Warfarin is higher risk. If you look at fatal bleeding, your risk of dying of bleeding on warfarin is about 47% higher. So these drugs reduce your risk of dying of bleeding by about half. And remember, they don't have reversal agents, whereas in the places these studies were done, they have reversal agents for warfarin. So in fact, despite the lack of a reversal agent, these drugs are much safer. The only difference is GI bleeding. There's about as much GI bleeding on the new agents as there is on warfarin. But for all the bleeding that we really worry about, fatal bleeding, intracranial bleeding, and major bleeding, the risk is statistically significantly lower with the direct oral anticoagulants than it is with warfarin. Next slide, please. This is evidence from the ROCKET AF study, which is the ROCKET atrial fibrillation study, and the Einstein DVT and PE study. So Xarelto is rivaroxaban, and if you just there's a bit of an animation here, so just click once. The relative risk reduction of fatal bleeding in ROCKET was about 50%, and just click one more time. Well, doesn't matter. You can see there, fatal bleeding in the Einstein study was also much less frequent with rivaroxaban compared to with warfarin. Next slide, please. So the summary is that new agents probably cause less bleeding than warfarin. When bleeding occurs, it's less likely to be serious. Overall deaths are reduced with the new agents, and that's in part because these agents are much less likely to cause intracerebral hemorrhage. And despite the lack of reversal strategies, DOACs are preferred to warfarin in most circumstances. So when I get a phone call from someone in Canada who says, I have a patient who's got a pulmonary embolism and I started them on warfarin, it's like, okay, let's go back to the start of this conversation. Next slide, please. In which patients should we avoid these medications? So the new anticoagulants are not panaceas. There are patients in whom should not get them. So advanced renal and hepatic disease, all the DOACs have some degree of dependence on the liver and the kidney for their excretion, so they should not get these drugs, particularly with severe renal insufficiency. For the people who are from the US in the audience, they might say, well, APIXABAN, that's way too complicated for most people, including me. I think in general, you should avoid DOACs if people have severe renal insufficiency, except in exceptional circumstances. And so all the new agents, they just shouldn't be used in these patients, but if you're going to use them in a patient with any of these things, you need to know what you're doing, and you need to be really familiar with them. Next slide, please. Pregnancy and breastfeeding. We don't know that these drugs are dangerous in pregnancy. They're small molecules. They will cross the placenta. They will anticoagulate the baby for sure. So around delivery, they're going to be unsafe. There's a study published looking at all the cases of exposure which occurred in Europe. Published last year, there was about 500 cases of people who were exposed in utero. No evidence of toxicity. But because we don't have any good quality evidence right now, we're recommending against the use in pregnancy. It does appear in breast milk, so you should not use them when they're breastfeeding. It's not known to be teratogenic. But so you should avoid it in patients who are or who may become pregnant or who are breastfeeding. So patients who may become pregnant, you need to, if you're going to use these, you need to tell them should they become pregnant, they need to stop the drug and they need to call you right away. That's the strategy that I use. The likelihood these drugs are teratogenic is really small, but we don't know that they're safe yet. And what should you use in these patients? So if they're pregnant, then you're going to have to use a heparin. There's little question about that. Again, sometimes if they have a mechanical heart valve and they're very stable, we'll talk about using warfarin during the second trimester, but in general, you're going to use a heparin through the course of pregnancy. The drugs do have a propensity to cause GI bleeds, so you should avoid them in patients who are perceived to have a high risk of GI bleeds. Next slide. You should definitely not use these drugs in people with mechanical heart valves. This is an absolute contraindication. This is another paper that John Eichelboom published in the New England Journal 5 years ago. They took patients with mechanical heart valves and they treated them with dabigatran. Next slide, please. And what this was a multi-center randomized controlled trial. The dabigatran dose was actually increased or decreased based on laboratory monitoring, which we don't do for any other circumstance with the DOAC. It was designed to show us how to do a larger clinical trial. Next slide, please. The dose was actually, in some cases, 300 milligrams BID, which is twice our usual dose. It's a very high dose. You can see there was dose adjustment, and we have trouble getting dabigatran levels in our place. There is no likelihood that you're going to have dabigatran levels in Uganda ever. You just aren't going to. So if you ever had to adjust a dose, this is a useless drug. So you're not going to use it, and the reason you're not going to use it is the next slide. So this is the probability of thromboembolic events. If the line is at 1 all the way across, it means there weren't any. You can see with warfarin, there were hardly any. And you can see with dabigatran, there were more. And the problem with this, of course, these are clots and mechanical valves, which is a near-death experience. It can kill people. Next. And unfortunately, this is bleeding. So not only were there more clots with dabigatran, there was more bleeding with dabigatran. Next slide. So the conclusion that John wrote for the study is there. Basically says you shouldn't use it because there's a high risk of bleeding, a high risk of clotting. We don't really understand why this happened. We kind of have some ideas, but there's no scientific evidence for it. It's not due to an inadequate anticoagulant effect because patients are bleeding. If you're driving anticoagulants into patients until they bleed, obviously they've got an anticoagulant effect. Next slide. So now, again, I don't want you to leave here thinking that, oh, the world's changed and when we get access to generic DOACs in Uganda, we should switch completely because the other drugs we used to use still have lots and lots of use. So low molecular heparins are still widely used. Heparin is still widely used. They provide flexibility because you can titrate the dose. So for very large people or very small people, you can fiddle with the dose until you produce a therapeutic effect. And for warfarin, as we said earlier, the one big advantage of warfarin is that you can monitor it. So if you're able to provide good quality monitoring, then warfarin can be a good choice. The bottom bullet here, anticoagulation is a high-risk activity, and thus you have to have a great deal of familiarity with the drug in order to use it successfully. Next slide, please. Why are you worried about renal insufficiency? You're worried because bioaccumulation can lead, I'm going to develop a cough, can lead to accumulation and renal and bleeding. Next slide, please. Henry, can you give me a drink of some sort? I need another one of those things. The reason why we worry about this is because if you take a patient who has renal insufficiency and you look at them at baseline, the renal insufficiency puts them at increased risk of both bleeding and clotting. This is without anticoagulants. So this is a study that Manuel Monreal published from his registry. And if you look on the left here, this is the risk of developing fatal pulmonary embolism. And you can see if your creatinine clearance is greater than 60, your risk is 1. That's the reference standard. And if you go down to a creatinine clearance of less than 30, your risk of having a fatal PE is 5. So your risk of dying from a PE is 5-fold higher if you have renal insufficiency. That has nothing to do, thank you, Dr. Dungu. We are actually brothers. And the story is quite funny because, so what happened is at birth we were separated. And I was, in Canada there's so much snow, I was left inside. And Henry was left outside, and this is what happens. And the reason why he's shorter is because he has less vitamin D than I have. And so he shrank a little bit compared to me. So, you bailed me out again. So fatal pulmonarism is higher with renals. This is without anticoagulants. And then the same is true for bleeding. So on the right-hand side, we have bleeding. And you can see that if your reference to creatinine clearance greater than 60, if your creatinine clearance is less than 30, your risk of having a fatal bleed is also 5-fold higher. So if you take a patient who's got a creatinine clearance less than 30, and you're going to anticoagulate them, you've got to understand that their risk of bleeding is way higher than someone with normal renal function, no matter which anticoagulant you use. So what happens is a person gets put on rivaroxaban and they've got a creatinine clearance of 20 and they have a bleed and people say, oh, the rivaroxaban bioaccumulated and the bleed was because it bioaccumulated. Go to the next slide though. That's not true. So this is great data which came from one of the big atrial fibrillation studies. And I'll go through this in a bit of a depth. So on the graph here, this is the GFR. So 120 is obviously really good and 30 is bad. And that going up is the 1-year event rate, stroke or systemic embolization. And what you can see is that as the renal failure deteriorates, There's two arms. There's the black one, which is the warfarin event rate, and then there's the long dashes, which are the APIXABAN event rate. You'd think that because APIXABAN, you know, the efficacy probably falls off or gets weird, something happens to the efficacy as the renal failure goes down, but we think warfarin works the same across the entire patient population because we use warfarin in people with renal insufficiency. What you can see is that as the creatinine clearance falls, the risk of having a stroke on warfarin increases about 4-fold. And that's not because the warfarin control is worse, it's because having impaired renal function when you have atrial fibrillation dramatically increases your risk of having a stroke. So you have to be careful. You can see here that APIXABAN is actually probably a better choice at a creatinine clearance of 30 because the increment in the risk of stroke is actually less. They both don't work as well, but APIXABAN works relatively better. Next slide, please. So the summary is care should be exercised in 95% of patients with renal insufficiency, but don't make the assumption that heparin or low molecular heparin or warfarin are safer than the alternatives just because occasionally you've seen a bleed in something else. It's because the renal insufficiency is increasing the risk of both thrombosis and bleeding, and it massively increases the risk. The rivaroxaban's advantage in fatal intracerebral hemorrhage, remember, it reduces the risk of fatal intracerebral hemorrhage by about 50% compared to warfarin, and renal insufficiency quintuples the risk. So the effect of renal insufficiency is dramatically larger than the effect you're going to see comparing one drug to another. Next slide, please. This is the last bit of the talk. You've heard enough of me shouting. Some more recent evidence. So one of the indications for long-term anticoagulation has been cancer-associated thrombosis. I think you probably all know that if you have cancer, you have a high risk of developing thromboembolism. The traditional long-term treatment for cancer-associated thrombosis has been low molecular weight heparin in North America, and if available, it would be here too, based on 3 randomized controlled trials. This is a very nice paper which was just published about a month ago. I was on the DSMB for this, so I have a bit of a conflict of interest. Not really though. And so what this does, this was a large randomized controlled trial which took patients who had cancer-associated VTE and randomized them to get traditional therapy, which is long-term low molecular weight heparin, as spelled out there, or edoxaban, which is one of the novel anticoagulants. We're not going to talk about edoxaban. It's got limited availability. I'm using this as an example. At a dose of 60 milligrams per day, which could have been reduced rarely. They were treated for at least 6 months, and the primary outcome was the composite of recurrent VTE or major bleeding during the 12 months after randomization. Next slide, please. And these are the event rates. So this is a composite endpoint of bleeding and recurrent thrombosis over 360 days. And the top graph just goes up to 20%, and you can see that there's no difference between dalteparin and edoxaban, and the bottom one is actually on a scale of 0 to 100. So you can see that there's no difference in a composite endpoint of recurrent thrombosis and bleeding. And so this is going to lead to a huge shift in the way we treat these patients in Canada and the United States. Now, we would never make a huge shift based on a single study. Simultaneously with this, there was a second study with rivaroxaban, which was much smaller, but showed exactly the same effect. And later on this year, there'll be a very large study with APIXABAN, which we don't know the results of yet, but I'd be deeply shocked if it's going to show anything different. So based on this, nowadays, you don't need to automatically go to low molecular weight heparin for patients who have cancer-associated DVT. The one caveat is that there was a signal for bleeding with the anticoagulant in patients with GI cancers. And so if the person has a gastric cancer, you probably should not use the new agents. You probably should stick with the low molecular heparin. Next slide, please. So there were 1,050 patients randomized. The conclusion was that oral edoxaban is non-inferior to dalteparin for cancer-associated VTE. It's a once-daily tablet. If you're a patient, you'd rather take a once-daily tablet than inject yourself once a day. It's the price differential in Uganda may be a bit different, but certainly in Canada and the US, the pill is going to be way cheaper than low molecular heparin. A daily injection of low molecular heparin in Canada probably costs somewhere around 3,000 times 30, so 90,000, 100,000 shillings per day. And these new drugs are going to cost vastly, vastly less than that, probably around 30,000 shillings per day or even less than that. So that based on these results of these studies, it is reasonable to use rivaroxaban or edoxaban for the treatment of cancer-associated thrombosis, and particularly in Uganda, where you may have trouble accessing a low molecular heparin, although I understand you can get it sometimes. These drugs are a really nice option that is probably going to be less expensive over the long term. Next slide, please. So I've got 3 cases just very quickly, which touch on the topic. 26-year-old woman presents with massive left leg swelling, and the ultrasound suggests proximal DVT of the left leg. She's had symptoms for several weeks. This is key. The long-term outcome of DVT is determined by how rapidly they're diagnosed. The longer you have this big, sore, swollen leg, the more the valves are going to be damaged, the more likely they are to get post-thrombotic syndrome. And again, Henry and I talk about cases all the time, and Clement and I have talked occasionally about cases. And if the person's had a big, sore, swollen leg for 3 weeks, and they come in and you anticoagulate them, the likelihood they're going to have a big, sore, swollen leg in a year is very high, that they're not going to get better. Their ultrasound is probably not going to change very much. So one of the key messages is the earlier you can diagnose DVT, the better, because the earlier you get them on treatment, the less likely they are to have persistent leg pain and swelling afterwards. She's had symptoms for several weeks. She's had episodic chest pain. So this gets back to your case. You don't need to investigate her for a pulmonary embolism. People have done that study. If this woman has a DVT of the leg and has chest symptoms, the likelihood she has a pulmonary embolism is more than 99%. That's scientifically shown. You don't need to know she has a PE. Just skip all that, because you're going to treat the DVT and the PE in exactly the same way. You're not going to thrombolyse the person unless they're hemodynamically unstable, which you can tell based on your examination of the patient, and she's not. So you don't need to do it anymore. So the most appropriate treatment, next slide. You can use the low molecular heparin, transition to warfarin, or you could use rivaroxaban, or you could use APIXABAN. Use whatever you want. Just make sure you do it as best you possibly can. The PE doesn't change management. The PE does not require investigation. One thing to think about, there is a side effect of the direct oral anticoagulants, particularly rivaroxaban, is it causes menorrhagia. So if you're treating young females with these drugs, you need to ask them about menstrual blood loss, because many of those people, particularly in Uganda, are already iron deficient, and you'll make it worse with these drugs. So you got to ask about that. And that effect does not appear to happen with warfarin, so that's an important thing. And again, she will likely have long-term leg pain and swelling due to PTS and as a result of the size of the clot and the delay in the diagnosis. That's not a sign of treatment failure. People will call me and say, she's still got a swollen leg at a year, and the ultrasound still shows clot. As if that has some importance. It has no importance. That's not a sign of... Henry's laughing because he asked me that in the car on the way from the airport. He said, I've got this lady. She's like way after her diagnosis. She's got a swollen leg and the ultrasound's abnormal. She's not... Henry, stop it. Stop it. Is that true, Dr. Nugu? It is true. Next slide, please. 32-year-old man has severe mitral valvular disease with a prior stroke and atrial fibrillation. So you would probably see this person occasionally. We never see these people. They don't exist for us. But for you, this person could well exist. There's no plan for surgical repair of his mitral valve. He has limited money, but wishes to reduce his risk of stroke. What's the best drug? Next slide. So the next slide is warfarin is actually the preferred agent here. Now you might say, Mark, show me the evidence for warfarin in valvular atrial fibrillation. There is none. There's not even a single crappy case series of 25 patients. There is absolutely not one paper on this. People talk about this and say, well, warfarin is the preferred agent for valvular atrial fibrillation. There's no evidence to support that. It's a reasonable hypothesis, but based on that study I showed you earlier, which was Realign, warfarin is very likely to be better than rivaroxaban or APIXABAN. So it's all conjectural. No evidence for DOACs with valvular heart disease, nor will there ever be any. But I would say the mechanical heart disease data probably means warfarin's a better choice. But remember, if the person can't get warfarin, they live somewhere out in the bush, and they can't get INR testing done, then use an anticoagulant. If you got rivaroxaban, then use rivaroxaban. If you've only got aspirin, honestly, like they really can't get anything at all, then aspirin is probably better than nothing. We would never use aspirin in Canada because it's probably very ineffective. But if you really don't have something else, then aspirin is probably better than nothing in this guy. Next slide, please. 64-year-old hypertensive diabetic woman presents with a new TIA. She has a loud right carotid bruit. I don't examine patients anymore because I have these machines all around me that help me to diagnose things. You guys still examine patients, so you would detect this. I would never detect this. Next slide, please. Just to go back to the future, aspirin is probably the preferred agent here. Aspirin's 100 and some odd years old, but aspirin is probably the agent here. You could use one of the new agents if you wanted to, because you want to use a new drug to increase expense, but in reality, aspirin is a very reasonable treatment. But the most important thing for this woman is to remember to modify other cardiovascular risk factors. Everybody's going to remember to put her on an antiplatelet because she's a youngish person with a stroke. But what you got to remember is her BMI is like mine. It's over 30. She's diabetic, whatever. Remember to modify her cardiovascular risk factors. Henry asked what to introduce me as, and he said, write down what you want to be introduced as, and I wrote obese. He didn't think that was good. Next slide, please. So the summary of the whole talk, thank you for your attention, is that the direct oral anticoagulants are highly desirable drugs in many situations, but are not a panacea. Expense may limit their use in Uganda, but it is very clear that warfarin is poorly done here, and that's not a criticism of you. We do warfarin poorly in our place, where you can easily access testing. There's no way that warfarin testing is done well in Uganda. I know it's not. And I also know that the labs here aren't subject to the same level of quality control as our labs are. So you have the double whammy of patients not being able to access labs. And the lab in the IDI is a great lab, and I would trust its INRs. But if you've got a lab that's in somewhere out, there's no way that that lab can be doing quality control the way that a lab should be doing quality control. Warfarin is clearly done, and the DOACs are appealing from a management perspective. They're easy to use. Once you understand the drug and the dose, you don't have to monitor, you don't have to futz around, you can treat patients highly effectively. So we just got to figure out the cost implications. I think that's the last slide. Thank you for your attention.